All right, welcome to question time. This is it. This is that final high-intensity push you need right before your exam.
Exactly. We've collected 300 of the most essential, high-yield clinical facts you really need to have locked in.
And our goal here is to cut through all the noise, lock in those crucial parameters, and give you the clinical context.
Yeah, the why. The why behind the answer is what turns memorization into real understanding.
So we're jumping straight in, no small talk.
Let's do it. We're starting with pharmacology crisis management. This is where a lot of the high-stakes test anxiety comes from.
Okay, let's unpack this. I think we should focus first on those drugs with the really narrow therapeutic indices, where the line between therapeutic and toxic is just razor thin.
Absolutely. And the first one that comes to mind is, of course, lithium.
Right. So for your final, you have to know the classic symptoms of toxicity: vomiting, diarrhea, those coarse tremors. But what's the number? What's the lab value that confirms it?
The number you have to burn into your brain is anything greater than 1.5 milli-UQL. That is toxicity.
Greater than 1.5. Got it.
But the fascinating part, the why that they'll test you on, is the mechanism. It's all about sodium. The kidneys handle lithium almost identically to how they handle sodium.
So if a patient gets dehydrated or suddenly drops their sodium intake.
Exactly. The kidneys panic. They try to preserve electrolytes, so they start aggressively reabsorbing lithium by mistake.
And that's how the level can just spike incredibly fast.
That's it. So the most crucial nursing intervention is teaching that patient about consistent fluid and sodium intake. It's everything.
That's a key distinction for those application questions. Okay, moving on to another high alert crisis: magnesium sulfate toxicity.
Right, which we primarily see in OB, right, to prevent eclampsia seizures in patients with preeclampsia.
So how do you know you've overshot the mark and the patient is toxic?
You're looking for signs of central nervous system depression. The two biggest red flags are absent deep tendon reflexes, or DTRs, and signs of respiratory depression.
And the absent DTRs, that's the big one, right?
That is the immediate, non-negotiable stop the infusion sign.
And the antidote, what are we grabbing?
You're reaching immediately for calcium gluconate.
And the reason that works physiologically is because it just rapidly antagonizes the effects of magnesium right at the neuromuscular junction. It reverses that depression. It's life-saving.
Exactly. And we have to have these core antidotes just memorized. Cold, so acetaminophen overdose.
Acetylcysteine, also known as Mucomyst.
Right. It works by replenishing glutathione in the liver, which is what detoxifies that toxic metabolite from the Tylenol.
Okay, what about a benzodiazepine overdose? Think profound sedation, respiratory depression.
The antidote is flumazenil.
But there's a huge caution there, isn't there?
Oh, a huge one. While it is the antidote, you have to be really careful. In patients who take benzodiazepines chronically, giving flumazenil can trigger severe, even fatal seizures because you're instantly reversing the drug's effects.
Clinical context always matters.
Always. Okay, now let's talk about critical care access.
Yes.
Specifically, what happens when a vasopressor like norepinephrine infiltrates an IV site?
Oh, this is a nursing emergency. These are vesicants. They will cause just devastating tissue necrosis if they get out of the vein.
Right, the area will look blanched, it'll feel cold, hard.
Yeah.
Your immediate intervention is to stop the infusion.
Stop it immediately. Then what?
Then you inject the antidote, which is phentolamine, subcutaneously, all around that infiltration site.
And phentolamine is an alpha blocker, so it works by causing local vasodilation to get blood flow back to that damaged tissue. It can literally save the tissue.
It's an absolute must-know prioritization.
Uh,
Okay, let's transition to psychopharmacology. We have to differentiate between three major crises
all
here.
right, let's go.
First, the patient is on a typical antipsychotic, like haloperidol. They suddenly develop a super high fever, profound muscle rigidity, and confusion. What is that?
That is classic neuroleptic malignant syndrome, NMS.
NMS. And that requires immediate, aggressive cooling and supportive care, often with muscle relaxants like dantrolene.
Okay, so we need to differentiate NMS from, say, an acute extrapyramidal symptom or an EPS, like a dystonic reaction.
Exactly. The dystonic reaction is more about those painful, severe muscle spasms, right? Often in the neck or the face.
Very distressing. But the priority antidote for that acute movement disorder is the anticholinergic, benztropine.
Right. And the third crisis is serotonin syndrome. This is often caused by combining an SSRI with another serotonergic drug.
So what's the key difference in presentation between NMS and serotonin syndrome?
Hyperreflexia. NMS tends to be hyporeflexic. Serotonin syndrome is hyperdynamic. You see rigid muscles, high fever, but also hyperreflexia, clonus, tremors, and tachycardia, recognizing that hyperreflexia is crucial.
That's a great test tip.
Yeah.
Okay, let's revisit some critical dietary and lab monitoring for psych drugs. Let's do MAOIs, like phenolphine.
That's the one with the non-negotiable dietary restriction. You have to avoid tyramine-rich foods.
Aged cheese, cured meats, beer, wine.
Right, because if you ingest tyramine, it releases norepinephrine, and since the MAOI is blocking its breakdown, the patient can go into a life-threatening hypertensive crisis.
And then that restriction also includes common over-the-counter drugs, right?
Yes. They have to avoid decongestants like pseudohedrine for the exact same reason. It's a sympathomimetic that will trigger that hypertensive spike.
And we can't forget clozapine.
Never. The big risk there is a granulocytosis, that critical drop in white blood cells. So you have to monitor the WBC count weekly.
And if you don't have that weekly WBC count,
You cannot dispense the medication. It's a hard stop.
okay, a quick but really vital check on SSRIs, like fluoxetine. You have to teach the patient and their family that the highest risk for suicide happens when...
During the initial weeks of treatment,
Why is that?
because the drug often gives them an increase in energy and motivation before it actually lifts their mood. So a severely depressed person suddenly has the energy to act on suicidal thoughts.
Close monitoring during that lag period is absolutely essential.
And speaking of lag periods, let's talk about buspirone. It's a non-benzo anxiolytic that gets missed on exams a lot,
Right. The key teaching point is that it takes 2 to 4 weeks to become effective.
which means it is strictly not for PRN, or as needed, panic attacks. It's not like a fast-acting agent. This tests your understanding of medication onset.
Okay, let's flip to the cardiovascular side. Let's hit the strict contraindications, the one combination that can cause fatal, profound hypotension.
That's combining nitrates with erectile dysfunction medications, like sildenafil.
Both cause massive vasodilation. Together, it's a disaster. It's a strict, hard stop.
Then there's digoxin. Toxicity is a level greater than 2.0 ngml, and you see those classic yellow or green halos in their vision.
But the priority nursing action before you even give the dose is what?
You have to check the apical pulse for 1 full minute,
1 full minute.
and you hold that dose if the heart rate is below 60 beats per minute. Digoxin can cause severe bradycardia.
Okay, now for the statins, like atorvastatin, what's the primary life-threatening adverse effect we're watching for?
Rhabdomyolysis. That's severe muscle breakdown. You need to be monitoring their creatine kinase or CK levels.
And the patient teaching for statins, there are a couple of key points.
Right. They should take it at night because that's when the body's cholesterol synthesis is highest. And critically, they have to avoid grapefruit juice.
Why grapefruit juice?
It messes with the CYP450 enzyme system in the liver, which raises the drug's serum level and dramatically increases that risk of muscle damage.
Good. Okay, ACE inhibitors, lisinopril, 2 main adverse effects. One is life-threatening.
That's angioedema, the swelling of the lips, tongue, throat. It's a rapid onset airway crisis.
And the other one is more of a chronic, annoying side effect.
The dry, hacking cough. And if the patient develops that cough, you don't just tell them to live with it. They typically get switched to an ARB, an angiotensin receptor blocker.
Also, ACE inhibitors can cause hyperkalemia, right? High potassium.
Yes, because they interrupt that whole renin-angiotensin-aldosterone system, which leads to the body retaining potassium.
And finally, in this section, beta blockers, metoprolol. Let's hit the 2 key contraindications.
First, you can't give them to patients with asthma or COPD because they can cause severe bronchoconstriction.
And second, for diabetic patients.
They are dangerous because they mask the signs of hypoglycemia. They block those adrenergic symptoms like tremors and palpitations.
So a diabetic patient on a beta blocker needs to be taught to watch for other signs, like sweating or confusion instead.
Exactly. And you always hold a beta blocker if the heart rate is under 60.
Perfect. 2 last notes on chronic disease pharmacology. Methotrexate.
Profoundly teratogenic. The patient requires strict contraception and a lot of counseling about the risk of fetal harm.
And hydroxychloroquine, or Plaquenil, used for lupus and RA.
That one carries a specific long-term risk of retinal damage. So it requires routine eye exams, often every 6 months, to catch that retinopathy before vision loss happens.
Okay, one final critical moment here. You're infusing a chemotherapy drug, it's a known vesicant, and the patient reports pain or burning at their peripheral IV site. What is your immediate, absolute action?
Stop the infusion. Immediately. That is the only answer. You have to prevent that tissue damage.
All right, let's keep this pace. We are moving straight into the world of cardiac rhythms, hemodynamics, and coagulation. Timing is everything here. Let's start with anticoagulation, contrasting the two big players.
For warfarin, you're monitoring the PT-INR, and that standard therapeutic range is going to be 2.0 to 3.0,
And the antidote for warfarin.
vitamin K. But the crucial patient teaching, the part that always comes up, is that they don't need to eliminate vitamin K-rich foods like leafy greens.
No, they just have to be consistent.
Exactly. They have to maintain a consistent intake. A sudden drastic change is what's going to throw off their INR.
Okay, so contrast that with heparin.
Heparin is monitored by the APPT, and let's say the patient's APTT comes back at, I don't know, 120 seconds, which is dangerously high. Their blood is too thin. What is your priority action?
You stop the infusion immediately. You stop the bleeding risk before you even think about calling the provider.
That's it. And if that bleed needs reversal, the specific antidote for heparin is protamine sulfate.
Knowing which test monitors which drug and their specific antidotes is is fundamental.
Absolutely. Okay, now for the rhythms. Let's talk supraventricular tachycardia, or SVT.
So a heart rate over 150 originating above the ventricles. If vagal maneuvers fail, the treatment is that chemical reset button.
Adenosine.
And the administration technique is a classic high-yield question. Why?
Because of its extremely short half-life, you have to give it as a rapid IV push. I mean, you're basically slamming it and then following it immediately with a rapid saline flush.
Just make sure it gets to the heart fast enough to work.
Exactly. And you have to warn the patient. They might experience a brief, terrifying moment of asystole before the heart converts. You need a crash cart right there.
Okay, on the other side of the rhythm spectrum is ventricular fibrillation, VFib.
That chaotic, pulseless rhythm. Immediately after you start CPR, what's the priority?
Defibrillation, shock. You have to use electricity to reset that disorganized electrical activity.
Yep. Now what about a slow, symptomatic rate? Sinus bradycardia. The patient is hypotensive, dizzy.
The first-line medication is atropine. It blocks the vagal nerve and speeds up the rate.
Right. But there's a huge contraindication that flips this whole rule upside down. When must you not give atropine for bradycardia?
When the patient is severely hypothermic.
And why is that?
Because the heart muscle in hypothermia is so irritable, it won't respond predictably to atropine. You can actually induce worse arrhythmias. The priority is to rewarm the patient first.
Perfect. We also have to connect these rhythms back to electrolytes. If you see frequent premature ventricular contractions, PVCs, what's the most likely cause?
An underlying electrolyte imbalance, specifically hypokalemia or hypomagnesemia.
You fix the electrolytes, you often fix the PVCs.
And some quick EKG notes, atrial flutter.
That's the characteristic sawtooth pattern.
And atrial fibrillation.
AFib is chaotic, and it places the patient at a dangerously high risk for stroke, because that blood is just pooling in the atria, forming clots that can travel anywhere.
Okay, transitioning to heart failure. This is all about understanding the fluid dynamics. Let's start with left-sided heart failure.
In left-sided failure, the blood backs up proximally into the lungs.
So the classic respiratory symptom you're going to hear on auscultation is
Crackles, rails. You're hearing signs of pulmonary edema.
Conversely, right-sided heart failure. The blood backs up where?
Into the systemic circulation.
So you're going to see systemic symptoms like peripheral edema, jugular vein distension, or JVD, and ascites.
Exactly. It's a difference between being wet on the inside for left-sided and swollen on the outside for right-sided.
We mentioned high-risk cardio drugs earlier. Let's talk about amiodarone.
Amiodarone is used for really stubborn arrhythmias, but you have to approach it cautiously. It carries a severe black box warning for toxicity in the lungs and the liver.
So that means pulmonary fibrosis is a risk for the lungs.
And you have to constantly monitor for any pulmonary symptoms or signs of elevated liver enzymes. It's mandatory.
Okay, finally, let's talk shock management and pressors. Before you just start blasting a hypotensive patient with potent vasopressors, you have to determine if they are what?
Fluid responsive.
And how do you test that quickly and non-invasively?
You can place the patient in Trendelenburg or just perform a passive leg raise. If their blood pressure increases significantly, it means they are fluid responsive.
So they need a volume bolus.
They need fluids. If they are not fluid responsive, then you proceed to vasopressors. But there's a limiting factor.
What is it?
Vasopressors will not work effectively if the patient has severe acidosis. The low pH makes the adrenergic receptors less sensitive to the catecholamines.
So the body just can't respond to the medication. You have to correct the acidosis first.
You have to correct the acidosis before those pressors will become fully effective.
All right, now we're entering the neurological crisis zone, where milliseconds matter. We need to focus on rapid recognition of a devastating change in status. Let's start with the classic sign of severe, late-stage, increased intracranial pressure.
That would be Cushing's triad.
And Cushing's triad represents the body's last-ditch effort to maintain cerebral perfusion as the brainstem is getting compressed. So what are the three specific signs?
It's hypertension, specifically with a widened pulse pressure, so a big gap between systolic and diastolic. Second is profound bradycardia. And third is irregular respirations.
This is a preherniation sign. It demands immediate intervention.
Right, and that intervention often starts with positioning and drainage. The gold standard for both monitoring and draining ICP is the ventriculostomy drain.
And for an accurate pressure reading, where does that transducer have to be physically leveled? This is a huge safety point.
It has to be leveled precisely to the tragus of the ear,
Why the tragus of the ear?
because that's roughly level with the foramen of Monroe, which is the reference point for intracranial pressure. Even a tiny height discrepancy can give you a grossly inaccurate reading.
Okay, when ICP is acute, what's the osmotic diuretic of choice?
Mannitol. Its job is to pull fluid from the brain tissue back into the vascular space so the kidneys can excrete it.
But you have to know the contraindications. When can you absolutely not give mannitol?
If the patient is anuric, meaning they have no urine output, or if the IICP is caused by an active cerebral hemorrhage,
Because it could make the bleeding worse.
it could, by dehydrating the brain tissue around the bleed.
Okay, we also assess for posturing. Let's talk about decerebrate posturing.
Decerebrate is when the arms are extended at the sides, with the hands flexed outward. Clinically, this is the worst sign.
And what does it indicate?
It indicates severe damage to the brainstem or the pons, which is below the level of the red nucleus.
Good distinction. Also, be aware of fevers that don't respond to typical antipyretics. A really high temp, say 103, that's not responding to Tylenol.
That's often a central fever. It's not caused by an infection. It's caused by pressure or damage to the hypothalamus, which is the body's thermostat.
Okay, switching gears. Stroke protocol. Patient presents with sudden neurological deficits. What is the absolute immediate diagnostic test?
A CT scan without contrast.
And the purpose of that test is singular, right?
It has one job: to rule out a hemorrhagic or bleeding stroke. That's what dictates whether or not you can give TPA.
Which leads right into TPA or Alteplase. What's the time window?
It's an incredibly narrow window, usually 3 hours from symptom onset.
But as a nurse, your primary concern is recognizing the contraindications. What are some absolute hard stops for TPA?
Any recent head injury or surgery or a recent lumbar puncture? The fibrinolytic action will just lead to severe, uncontrollable bleeding.
And if your patient on a TPA drip starts showing signs of bleeding anywhere...
You stop the infusion immediately.
Okay, for patients recovering from a stroke, let's talk about visual deficits, specifically homonymous hemianopsia.
That's the loss of half of their visual field. The critical safety teaching for them is to train them to scan the room. They have to physically turn their head to see that affected blind side.
To prevent falls and injury. Okay, and what about after a carotid endarterectomy?
So they've just had the plaque cleared out of their carotid artery. Your immediate post-op focus is monitoring for a developing hematoma at the surgical site.
Because that hematoma can expand rapidly and compress the trachea.
Exactly. Airway compromise is the priority concern.
Okay, finally in this section, we have to solidify the protocol for autonomic dysreflexia.
Right, this occurs in patients with a spinal cord injury at T6 or above. They get a sudden pounding headache and severe, dangerous hypertension. What's the immediate life-saving intervention?
You have to first sit the patient up, high Fowler's position. Use gravity to help lower that blood pressure.
That is the immediate action. Then, and only then, you check for the cause.
And the most common culprits are an overdistended bladder, maybe from a kinked catheter or a bowel impaction.
Right. And you have to address this. Failure to fix it can lead to a hemorrhagic stroke.
We're diving right into renal function now and the high-stakes management of fluid and electrolytes, especially in chronic kidney disease or CKD. Let's start with a unique late-stage sign.
Uremic frost. You'll see these crystallized salt deposits on the skin, and they cause just intense itching. It's a sign of severe CKD or end-stage renal disease.
For these CKD patients, nursing safety is huge. It involves strict medication avoidance. What can they absolutely not have?
2 big categories. They must strictly avoid NSAIDs, like ibuprofen or naproxen, because of their nephrotoxic effects.
And certain antibiotics.
Yep, particularly the micanomycins, the aminoglycosides. They can cause further damage to the kidneys.
But conversely, we also use a common antidote to protect the kidneys, right?
Mhm.
Like before a CT scan with IV contrasts.
Exactly. We often administer acetylcysteine or Mucomyst beforehand to provide that protection.
Okay, the highest stakes electrolyte crisis in CKD is often
Hyperkalemia, high potassium.
to rapidly stabilize the patient and shift that potassium back into the cells away from the heart. What do we administer?
We give the combination of insulin and dextrose, D50.
So the insulin acts as the key to unlock the cells and shuttle the potassium in.
Right, and the dextrose is just there to prevent the patient from bottoming out their blood sugar. It prevents iatrogenic hypoglycemia.
Okay, that's for the acute crisis. For long-term potassium management, we use.
Kayexalate. It works by binding potassium in the GI tract and then excreting it through the stool. It's a much slower, more sustained method
CKD also causes chronic anemia. Why?
because the kidneys fail to produce enough erythropoietin. So to treat this, we give epoetin alpha, which stimulates the production of red blood cells, hemoglobin, and hematocrits.
We also need to manage phosphorus in CKD patients. They often have hyperphosphatemia.
Right, so we use phosphorus binders like Foslo or Sevelamer. The critical point about this medication is that it must be taken with food, with meals.
It has to be in the GI tract at the same time as the food to bind that phosphorus.
Exactly. Okay, let's talk dialysis access,
Yeah.
specifically the AV fistula. This is a lifeline, and we have to preserve it. What are the 3 absolute restrictions on that arm?
No blood pressure readings, no blood draws, and no IV starts, period.
And you also have to know how to assess a healthy fistula
Right. You assess it daily for patency. You should be able to feel a vibration or a thrill.
and hear a whooshing sound, the brood. Those are normal, and they indicate good blood flow.
Okay, let's move to peritoneal dialysis, or PD. What's the major catastrophic complication we're watching for?
Infection. The critical sign of peritonitis is cloudy outflow or effluent or a rigid board-like abdomen. This is an emergency.
Now, if a patient on PD just reports poor or insufficient outflow, what's the first non-invasive thing you should try?
Just reposition the patient. Often the tip of the catheter is just resting against tissue, and a little movement can restore that drainage.
Okay, finally, 2 renal pathologies. Acute glomerulonephritis, what's the most common cause?
A preceding group. A beta hemolytic strep throat infection.
And what's the priority dietary restriction to manage the acute symptoms of fluid overload and hypertension?
Strict sodium and fluid restriction.
And the other one, nephrotic syndrome, what's the hallmark symptom here?
Massive proteinuria. So much protein is lost through the kidneys, specifically albumin. This causes the hallmark symptom you'll see, which is foamy or frothy urine.
We are transitioning now to maternal child health, focusing on those critical safety parameters and immediate newborn assessment. Let's start with a high alert OB medication, oxytocin or pitocin. When do you stop the infusion?
You have to stop it if contractions last longer than 90 seconds, or if they're occurring less than 2 minutes apart.
That's uterine hyperstimulation.
Right. Or if you see any fetal distress on the monitor, like late decelerations. Hyperstimulation can lead to fetal hypoxia or even uterine rupture.
Okay, for the Rh-negative mother, when is RhoGAM administered?
She gets it at 28 weeks gestation as a prophylaxis, and then again within 72 hours postpartum if the baby is found to be Rh positive.
And this prevents the mother from developing antibodies against any future Rh positive babies.
Correct. Now, we talked about magnesium sulfate earlier. In preeclampsia, it's given to prevent.
Seizures. Eclampsia.
And the nursing intervention is being hypervigilant for the warning signs that a seizure is about to happen. What are those?
A severe persistent headache and visual disturbances.
Those are the big ones. Okay, what about for impending preterm labor? What steroid is given to the mother?
Betamethasone. It's given intramuscularly to mom to stimulate the production of surfactant in the fetus.
Right, it promotes rapid fetal lung maturity.
Okay, one of the most terrifying OB emergencies. Umbilical cord prolapse. The goal is rapid pressure relief. What's the priority position for the mother?
Trendelenburg or knee chest. You're using gravity to get the baby off the cord.
And what is the nurse's immediate critical intervention?
You insert a sterile gloved hand, and you physically lift the presenting part, which is usually head, off of the cord. And you do not remove your hand until that baby is delivered, typically by emergency C-section.
Okay, postpartum hemorrhage prevention. It starts with assessing the uterus. A boggy uterus indicates what?
Uterine atony. The muscles are relaxed and they're not clamping down on those blood vessels. So the priority intervention is aggressive fundal massage.
Now, what if that boggy uterus is also displaced upward and to the right?
The cause is almost always bladder distension. That full bladder is preventing the uterus from contracting effectively.
So you have to address the bladder first, maybe with a straight cath, before you can effectively massage the fundus.
Exactly. But a crucial safety note. While massage is necessary, you have to avoid over-massaging.
Right, because aggressive, prolonged force carries a severe risk of causing uterine inversion, where the uterus turns inside out.
A terrible complication. Also, remember the immunization rule. Live vaccines like MMR or varicella are absolutely contraindicated during pregnancy.
Good. Switching to the newborn, the APGR score, what are the 5 components?
Its appearance, pulse, grimace, activity, and respiration, and it's assessed at 1 minute and 5 minutes after birth.
You have to know your newborn normals. Let's talk about cyanosis.
Okay, acrocyanosis, which is blue hands and feet, is normal for the first few hours, even up to 24 hours after birth.
But what is not normal?
Circumoral cyanosis, blueness around the mouth or on the trunk, that is not normal and indicates serious cardiopulmonary distress.
Okay, let's clarify the 2 types of head swelling. Cephalohematoma.
That's a collection of blood that does not cross the suture line, but because it's blood breaking down, it carries a risk for jaundice.
And caput succedaneum.
That's just soft tissue swelling that does cross the suture line, and it's generally benign.
Okay, newborn hypoglycemia. This is a rapid crisis. What are the signs?
Jitteriness, lethargy, or temperature instability.
And if the blood glucose level is low, say less than 40, what's the priority intervention?
Feed the infant immediately. Also, remember that cold stress dramatically increases the risk of hypoglycemia because the infant burns through glucose just trying to stay warm.
And we have to note the newborn prophylaxis trio. What are the 3 medications every newborn gets?
First is the hepatitis B vaccine within 12 hours of birth. Second is vitamin K to prevent hemorrhagic disease. And third is erythromycin eye ointment.
And that's to prevent ophthalmia neonatorum, which is typically caused by gonorrhea or chlamydia exposure.
Correct. Moving into pediatrics, developmental dysplasia of the hip, or DDH. What's the physical sign you look for?
Unequal or asymmetrical gluteal folds, or a leg length discrepancy.
Perfect.
Yeah.
For children with tetralogy of Fallot, we teach parents that what position helps alleviate a TET spell.
Squatting.
And why does squatting work?
Because it increases the systemic vascular resistance, or SVR, which forces more blood flow across the pulmonary valve and into the lungs to get oxygenated.
Excellent. 2 critical GI issues in kids. Pyloric stenosis, the hallmark is.
Projectile vomiting. And the infant is still hungry afterward.
Right. And cystic fibrosis, they need replacement enzymes. What's the rule for pancrelipase?
It must be taken with every meal and every snack to ensure they can absorb fats and nutrients.
And finally, Hirschsprung's disease should be suspected if the newborn does not pass what?
Meconium, within the expected 24 to 48 hours of birth. This next section is all about disaster medicine and emergency response. It's your ability to prioritize under chaos. We have to start with triage tags.
Let's do it. Remember the colors. Red tags mean immediate.
So these are patients with life-threatening injuries, like a sucking chest wound or a really high respiratory rate, but they have a high probability of survival if we treat them now.
Exactly. Green tags are minimal.
The walking wounded, closed fractures, minor cuts, they can wait.
And the black tag is for the expectant or deceased.
Massive head injury, unresponsive, agonal breathing. We have to divert resources elsewhere.
It's a tough call, but it's the reality of mass casualty incidents.
Okay.
Moving to burns and the airway. If a patient has a smoke inhalation injury, what's the big pitfall with pulse oximetry?
Their SpO2 reading might be normal even if they are dangerously hypoxic.
And why is that?
Because the pulse oximeter can't tell the difference between oxygen and carbon monoxide attached to the hemoglobin.
It gets fooled. So you had to treat for carbon monoxide poisoning regardless of a normal SpO2 reading.
You also have to be able to rapidly estimate burn size using the rule of 9s. So, for example, the entire left arm plus the entire left leg.
That's 9% for the arm plus 18% for the leg, so 27% total body surface area burned.
For fluid resuscitation in severe burns, what's the fluid of choice?
Lactated ringers,
Yeah, we are.
because it helps buffer the metabolic acidosis that happens after a major burn.
And what's the quickest and most reliable way to assess if your fluid resuscitation is adequate?
Urine output. You're aiming for at least 30 millipowers per hour in an adult.
Now, electrical burns carry a specific high risk, even if the surface injury looks small.
Right. The current damages deep muscle, causing rhabdomyolysis, which releases myoglobin into the bloodstream.
And that leads to myglobinuria, which is that dark, tea-colored urine. It's a huge threat to the kidneys.
So they need aggressive fluid resuscitation. For topical agents, we use things like silver sulfadiazine to prevent infection, but you have to check for an allergy too.
Sulfa.
Always check for a sulf allergy. Okay, chemical burn protocol, it's non-negotiable and immediate. What do you do?
Flush with water, continuously, for at least 20 minutes, maybe more. You have to remove that chemical agent.
Perfect. Turning to toxicology. For cyanide poisoning, which you often see in smoke inhalation patients, what's the specific antidote?
Hydroxycobalamin.
And if a patient has ingested an unknown quantity of pills and they're stable, what's the general intervention?
Activated charcoal. It binds the toxin in the GI tract before it can get absorbed systemically. For a patient with acute alcohol poisoning, especially if they're altered and vomiting, what is the absolute priority?
Securing and protecting their airway to prevent aspiration.
Okay, let's talk spider bites. Know the key differences. Black widow spider bite.
That affects the neurological system. You're worried about cerebral edema and seizures.
And the brown recluse spider bite.
That one is known for causing significant localized tissue necrosis, loxoscelism.
If you have to give antivenin, you must assess the patient for a prior allergy to what?
Horses or sheep? Because the antivenin is commonly produced by injecting venom into these animals to harvest their antibodies.
Good detail. Final 2 points on environmental crises. A patient is severely hypothermic and bradycardic. Remember the rule.
Atropine is contraindicated. You have to prioritize rewarming the patient.
But rapid rewarming has its own danger. What is it?
The risk of distributive shock is all that peripheral vasculature vasodilates too quickly.
And finally, rabies exposure. This is a unique situation.
Yes. The treatment, the vaccine, and the immune globulin must be given before symptoms start.
Because the chilling fact is that once clinical symptoms of rabies appear, it is virtually uniformly fatal.
Let's discuss managing immune compromise, critical blood disorders, and life-threatening respiratory conditions, starting with neutropenia.
Okay, so the patient has a critically low white blood cell count. Due to the extreme risk of infection, neutropenic precautions mean avoiding anything that carries bacteria or fungus.
Which means no open lightings, fresh flowers or plants, no raw fruits or vegetables, and avoiding crowded areas.
A major crisis for oncology patients just starting chemotherapy is tumor lysis syndrome.
Right. When a large number of cancer cells die off rapidly, they burst open and release all their intracellular components into the bloodstream.
And that leads to a dangerous trifecta of electrolyte imbalances. What are they?
It's hyperkalemia, so high potassium, hyperphosphatemia, high phosphate. And as a result of the high phosphate, you get hypocalcemia, low calcium.
Okay. To treat neutropenia, we use stimulating factors. What's the main one?
Filgrastim. It stimulates the bone marrow to produce white blood cells, specifically neutrophils.
But you have to remember the lag time.
Crucially, yes. It takes 2 to 4 weeks to really start showing a significant effect on the patient's count. It is not an immediate fix.
Newer therapies like monoclonal antibodies such as infliximab carry their own risks.
They do. They suppress the immune system in a very targeted way, but they carry a severe black box warning for an increased risk of serious or fatal infections.
Particularly reactivation of latent tuberculosis.
Exactly. Okay, autoimmune teaching. Systemic lupus erythematosus, or SLE. What's the classic facial sign?
The butterfly rash across the cheeks and nose. The malar rash.
And what is the single most important teaching point for SLE patients?
They have to strictly avoid sunlight and UV exposure, as it's a major trigger for an acute flare-up.
Contrast that with rheumatoid arthritis, where the hallmark is severe joint stiffness that's typically worst when?
In the morning. And it usually improves with movement throughout the day.
Good. Hematology crisis. Sickle cell crisis. The excruciating pain comes from vaso-occlusion. What's the primary treatment protocol?
HOP, hydration, oxygen, and pain control.
Aggressive pain control. And crucially, there's one opioid you must avoid in sickle cell patients.
Demerol or meperidine.
And why?
Because of the risk of neurotoxicity, which can lead to seizures.
Right, and a life-threatening complication of sickle cell is acute chest syndrome. What does that look like?
It presents with new chest pain, fever, and a cough. It looks like pneumonia, but it's caused by sickling in the lungs' blood vessels. It's an emergency.
It is. Now, for chronic management of sickle cell, we use hydroxyurea. How did that work?
It works by increasing the production of hemoglobin F, or fetal hemoglobin, which is resistant to sickling.
And because this drug is a toxic carcinogen, the nurse must always do what when handling it?
Wear gloves, absolutely. It also has a black box warning for causing severe immune suppression.
Good. Hemophilia A is simply a deficiency in which clotting factor?
Factor 8.
Okay, quick note on HIV/AIDS. What CD4 count confirms the progression to AIDS?
A CD4 count of less than 200.
And this severe immunosuppression places the patient at the highest risk for opportunistic infections, especially.
Pneumocystis jirovecii pneumonia, or PJP.
They may also develop Kaposi sarcoma, which are those purple or blue bruise-like lesions.
Okay, final airway crisis in this section, Guillain-Barré syndrome.
This is an ascending paralysis. It
Yeah.
starts in the feet and moves up. Because of that, what is the priority nursing diagnosis?
Ineffective breathing pattern or impending respiratory failure. You have to constantly monitor their vital capacity.
Perfect. And of course, anaphylaxis. If a patient develops signs of airway compromise, like stridor or wheezing, what's the priority medication?
Epinephrine, IM, or Racemic.
And after using an EpiPen, you have to teach the patient to immediately do what?
Massage the injection site and go straight to the hospital.
Right, because the effects of that EpiPen wear off and the reaction can rebound.
And finally, for a patient with acute shortness of breath and chest pain, what's the quickest diagnostic test to confirm a pulmonary embolism, or PE?
The VQ scan.
We're on the home stretch. We're wrapping up with the final essential facts covering sensory loss, chronic disease, and general safety protocols. Starting with vision, open-angle glaucoma.
This is characterized by a gradual loss of peripheral vision. It's often described as tunnel vision.
And that loss of peripheral vision increases the risk of falls, so safety measures like getting rid of throw rugs is key.
Right. Now contrast that with acute or closed-angle glaucoma.
This is an abrupt blockage of fluid flow. It causes sudden, severe pain, and the patient reports seeing halos around lights.
And this is a non-negotiable medical emergency. It needs immediate pressure-lowering medication.
Okay, when we're administering eye drops, what's the high-yield technique we need to teach the patient to prevent systemic absorption?
This is especially important if the drops contain a beta blocker. They have to use punctal occlusion.
Which is applying pressure to the lacrimal duct, that inner corner of the eye, for about 30 seconds after they put the drop in.
Exactly. Okay, then we have retinal detachment. This one is often painless, but the symptoms are dramatic. What does the patient report?
They report seeing a curtain closing over their vision, a sudden increase in floaters, and flashing lights.
And macular degeneration.
That involves the loss of central vision. It makes fine, detailed tasks like reading and driving extremely difficult.
Okay, for eye injuries, a chemical splash, what's the immediate action?
Flush with water continuously for at least 20 minutes before you even think about assessing your vision.
And if the patient has a penetrating injury, an object stuck in the eye?
You stabilize the object, you do not remove it, and you cover both eyes to prevent the injured eye from moving via consensual movement.
Perfect. Post-operative cataract care is all about preventing increased intraocular pressure, or IOP. What must the patient avoid?
Any action that increases IOP, specifically bending at the waist or straining during a bowel movement,
And how should they sleep?
on their non-operative side or on their back.
Good. Quick GI check. Celiac disease requires a lifetime, strict.
Gluten-free diet. No wheat, barley, or rye.
Endocrine management. Levothyroxine for hypothyroidism must be taken when?
In the morning on an empty stomach. About 30 to 60 minutes before food to make sure it's absorbed properly.
And for diabetics, the Somogyi effect. That's morning hyperglycemia, caused by an undetected rebound from nighttime hypoglycemia. How do you prevent it?
You give them a small bedtime snack to stabilize their glucose levels overnight.
Excellent. General safety. Before any surgical procedure, the purpose of a timeout is the final, non-negotiable verification of what three things?
The correct patient, the correct site, and the correct procedure.
And if a patient is on droplet precautions for something like influenza or meningitis, what must the nurse wear?
A surgical mask anytime they're within about 3 feet of the patient.
Finally, when you're initiating feeding for a severely malnourished patient, you have to monitor them closely for refeeding syndrome.
Right. And this is characterized by dangerous acute drops in which key electrolytes.
Potassium, magnesium, and phosphorus.
You just navigated a high-velocity, comprehensive review covering 300 essential questions across every major body system and clinical crisis.
You did.
Mm.
You have consolidated the critical facts, the numerical parameters, the immediate antidotes, and the prioritization frameworks that define safe clinical practice.
The information is now organized, it's solidified. You need to go into that exam with the confidence that you understand not just what to do.
But the clinical why behind every single protocol. Trust the prioritization framework you just established. You know what is life-threatening, and you know what the immediate nursing action is.
Absolutely. You have earned this, and you are prepared. Go get that degree. We are wishing you the absolute best of luck on your final exam.
You ready?
We'll see you next semester.